Just going to go over really briefly opioid agonist treatment in pharmacy. And I really, really appreciate the medical writing team for helping us get everything together and part of the HUD team as well. So at the end of the session, you'll be able to describe opioid agonist treatment options, some common drug-drug interactions. There's a table there that you could cut if you're practicing or you're wondering about it in general so that you have it on hand. Common errors when writing OAT prescriptions. And if you are an individual receiving a prescription, what are we looking at before you leave an office? That makes it a lot easier. Logistics about OAT or opiate agonist treatment, administration, witness doses, and some of the missed doses, which I'll go over really briefly. And again, if there's questions, you could text it in or connect back a bit later. I will also actually talk a little bit about the expansion of pharmacy services, just because everything got announced in the fall, including some of the injections, prescription extensions, which is relatively new and you might not be as aware of it. So very common, this is just a table of the oral opioid agonist therapy. There's injectable opioid agonist therapy and also monthly subcutaneously injectable opioid agonist therapy, which is the extended buprenorphine, or otherwise known as, people might know it as Sublocade. So methadose, the pink one, and methadone D is the ones that we mix in orange. It is interchangeable under BC, the Health Professions Act, and it is covered under pharmacare. So depending on the patient, some people prefer one over the other. And you can, as a patient, ask the pharmacy for a different choice depending on what you're interested in or what you're comfortable with. That's the most important thing. The compounded methadone is a non-benefit. And again, you've seen over time that switching from one methadone formulation to another might lead to some withdrawal effects. And it's unclear why this is so, but the most important thing is really the patient, what they're comfortable with. The next slide actually describes really briefly what methadose is. It's pink, it describes it. Methadone D is no color. It contains some sugar and you mix it with Tang most usually. And it is a benefit. So the chart is more there for benefit status if you're not sure when you're starting new, if you're practicing. Compounded methadone needs a special authority process and a trial of at least the other two. There is still the methadose sugar-free that some people might still be on right at the beginning quite a few years ago, but should a person need it, it is another special authority status. So really briefly, I like this chart. So sometimes it's just good to have a chart around to understand drug interactions overall in terms of a category. So it includes examples of drugs where there's a drug-drug interaction present. So for example, if you use CNS depressants and opioid agonist therapies together, of course, it will potentially increase the risk of respiratory depression, the sedation, the coma, etc. Alcohol medications containing alcohol are still contraindicated. It's not as much out there right now with some of the cough syrups that used to have a lot of alcohol, but if it's used, it's very mindful. The clients or patients should be asking, what is in certain medications. And of course, certain other medications, there's potential increased risk of serotonin syndrome, which as a prescriber, you'll probably get a call from a pharmacist. And as a client or a patient, you'll get a thorough explanation of what's going on in terms of a potential drug interaction. In terms of PharmaNet, so PharmaNet is this provincial system that in British Columbia, it's all your medications from a community standpoint actually is entered on PharmaNet. And some of the tips is when a clinician or a prescriber or a nurse or somebody in clinic is looking at PharmaNet, even you as a patient, when you're looking at your records, there's certain numbers called PINs. So PINs really varies according to delivery or witness doses of methadone. All it does is identify the type of drug, for example, methadone. Is it a witness ingestion or has it been delivered? Directions are very specific. If you're looking at it from, the PharmaNet, trying to understand things, liquids are entered by volume. So methadone, for example, if it's 100 milligrams, it's entered as 10 mils. And then the text is displayed in the field, but sometimes it gets cut off. And if it does get cut off, you can go call the pharmacy to find out what the rest of the text is. If the prescription is to be delivered to the clinic, would be ideal to enter when you're writing a prescription. And of course, if a nurse is to administer, it is much easier to just write deliver to a clinic for a nurse to administer. And if, for example, you need to identify where is this patient going to, because sometimes the patient might go to different pharmacies, you can actually call PharmaNet, and there's a medical number, practitioner line, that a prescriber can call to find out where this person might be getting their last prescription for, if the patient is not quite clear of where they had obtained it from, because you need a specific name of the pharmacy to locate the phone numbers. So the other thing, to give you an idea of common codes that pharmacists identify, is sometimes when pharmacies fill prescriptions either at the beginning of the day or when patients show up. So if a pharmacy fills prescriptions at the beginning of the day and the client doesn't show up, they might use a code to reverse, saying that the person never picked it up. The other items that you might see on the PharmaNet is emergency fills. On our end in pharmacy, we put certain codes in. On the actual field itself, it'll say emergency dispense of a prescription. It could be anything like even an opioid agonist therapy. It could be regular medications as well. Sometimes medications might be filled early because the person is going away. And then we will also have certain codes that indicate whether or not it was filled early or not. You might see certain codes in PharmaNet that actually may or may not identify that we actually change some things due to a conversation with the prescriber, and that's mostly on the pharmacist end of things. If there's a description when you're talking to the pharmacy about it, it's actually a pharmacy facing code. You might not see this you will not necessarily see this on the PharmaNet end when you are looking at it from a clinic's perspective. So prescribers, the main thing here, which I wanted to bring up, and it's been missing from what I understand conversing to individuals that are looking at data, prescribers are actually asked to add SA, or safer alternative, to all prescribed safer supply prescriptions. And then on the pharmacy end, we are also asked on our pharmacy software end that when we transmit this prescription, we enter that code SA. It is our facing software end, but what it does is that it allows prescriptions to be monitored and evaluate of the safer supply prescriptions. So this is really important to do. And if I understand correctly, sometimes this is being missed right now, and it throws the data off a bit to try and understand utilization of safer alternatives. One main thing that we've always encountered from the pharmacy, and I do practice in a community pharmacy, it's so important not to end a prescription on the day before a stat holiday, because sometimes, as you know, what will happen is that sometimes clinics close pretty early, or there's a special closure date, or people take some time off. And oftentimes it's really hard to reach somebody to correct a prescription if there needs to be a correction, or perhaps the client may have missed an appointment. So the other thing, of course, is if needed, instead of carries when closed, from our legislate or from the pharmacy perspective, we actually need to have a specific date to allow carries to occur. So it'd be appreciative if prescribers can indicate on the prescription, the exact date And again, if you note on the prescription, the person is also utilizing other opioids like safer supply or benzos, you can note that, yes, understood, it is being used and co-prescribed at the same time, just in case if the prescribers are different, because that actually will allow less callbacks to the clinic to clarify, because we must clarify when we find the drug interaction. And again, witness ingestions if there's special instructions, which has been done really well over the times that the different duplicates has been written. And then again, errors can occur, but it's gotten a lot more that less errors have occurred now, with some examples that have been floating out there on the best ways to write a prescription. So the thing that helped actually was a new harmonized controlled prescription program form. We call it a CPP form. So originally, if you look back, and especially some clients that are on this call or patients, is you remember there used to be like a blue form and a pink form, different types of forms. As a clinician, you will remember, well, there's 2 different pads, things like that. So there's a new harmonized controlled prescription program form now. And when the other 2 forms are used up, most likely, and a lot of people are actually already using this harmonized form, and it's really a consistent approach to writing not just methadone or not just Cadian, but also other controlled drugs such as fentanyl or other medications that fall under this category 1A drugs in British Columbia. And really, it makes it a lot easier, and it reflects a lot of things on this form that makes it easier for decision making for delivery of medications, as an example. So this is an outline of the harmonized prescription program form. And the first one on the left here is pharmacists can use our judgment to see if we can deliver or not before it needed to be written by the prescriber. The space is actually quite a bit bigger now in terms of being able to write certain things in that space, such as different instructions that I will go over for buprenorphine, naloxone, for example, and also naloxone, and also other things needs to be completed on this area here. So it's a little bit more clearer, and it's also one form. And for a client or a patient, it's important to just have a quick read of the prescription, just like any other times for any prescriptions, just to make sure that all the information relatively seems to you is correct, including the dose. So tips for low dose. I'm just going to go over a little bit about low dose buprenorphine naloxone prescription. So these are just some tips. Low dose directions, like, there's a lot of writing, right? Some people do type it in, keeping an extra copy for yourself at the clinic. Others handwrite, that's a very small space. And in it, a lot of individuals or prescribers do include instructions for continuing either other OAT prescriptions while you're titrating up this buprenorphine naloxone. So for example, continue with methadone at whatever milligrams it is. Dates and schedules for carries are important. And of course, instructions for missed doses is particularly important in low dose inductions. This is just an example, and it is located on the College of Pharmacists of BC website, really good examples of sample prescriptions. In some of our POTS-P that you might be looking at in some of the modules, there's also examples in there. So that's why I was saying that it's easier and less errors in writing now that there's examples on the websites as well. So this is an example of a simple induction prescription of buprenorphine naloxone. The next one is a little bit more complicating, where there's a low dose induction sample prescription. And you can see it's really tiny here in terms of the instructions, but some folks can write really well too, and they do handwrite certain things. What's really important here is what happens in a missed dose. If we're on day 3, for example, what do we need to do to support the patient in a pharmacy environment? This is an example of a Cadian or slow release oral morphine capsule, and really straightforward. Right now, if sprinkle is not needed, you just say no sprinkle. Pretty much straightforward in terms of a slow release or morphine. You have the start and stop dates written. You have all the milligrams written out accordingly. And again, it's actually a lot more space compared to previous old scripts. Methadone maintenance, again, really straightforward. What's really important in the programming and what a lot of pharmacists have indicated is sometimes the programming on the clinic's end, it doesn't include 10 milligram per mil. This is so important to include because there's different solutions out there for pain, for example, and it is a requirement on this form. Otherwise, pharmacy is actually filling against the requirements. A person can write Methadone D if you want, if in terms of specifically wanting to highlight that the client prefers that. It's not needed because at the end of the day, it's up to the patient, and the pharmacist needs to have a conversation with the patient too in terms of what he or she or what they would like in terms of a formulation. So that's just a discussion that can be had at the pharmacy end. So witness ingestions, I just wanted to go over a little bit about this. So for buprenorphine, naloxone, it is up to the prescriber's discretion whether or not the first dose should be witnessed. It doesn't need it to be witnessed at all. And really a witness ingestion is just putting the tablet on the tongue. And no, you do not need to wait at all before leaving the pharmacy. Slow release or morphine as it stands right now from our pharmacy protocols there, practice policies, it's always witnessed with further instructions. And should it be different, it has to be really written out clearly and have a discussion with the pharmacist. And again, we mentioned that capsules can be provided whole. What's really easier, much easier is because opioids are quite drying to the system too, I always suggest like drinking a little bit of water before even partaking in some of the sublingual aspects of the buprenorphine naloxone, or with a slow release or a morphine. If it is open, the pellets are hard to swallow because there's a little bit of small pellets throughout, and it's just easier to wet the mouth a little bit. And also, as a even if it wasn't open, it's a gelatin capsule, so sometimes it's really hard when the mouth is dry. So that's just something to think about from the pharmacist's end, or if nursing is witnessing, that's also something to consider. So with methadone, again, first dose is always witnessed, doesn't need to be diluted with a method dose formulation. Methadone D formulation, it has to be made up to 100 mils in total, usually of Tang. And in the monograph itself, it also has apple juice, Allen's apple juice, because originally that was what was studied. Really important too, because methadone, it's a liquid formulation. It looks like juice, especially if a person is traveling or visiting grandkids or kids, even pets. Like the pets are really smart, is that these medications should be kept in lock boxes. Logistic wise, just consideration so that everybody is aware. Partial ingestion, if a person only partially ingests something, on PharmaNet, we actually have to enter what is actually ingested. And then we communicate to the prescriber, usually by fax, what was ingested. Vomited doses, again, we contact the prescriber, and if it was to be replaced, it's easier to write a new script to be replaced. And now we can actually do emergency, again, notifying the prescriber of what was going on in terms of everything and keeping everybody in the loop for if a person vomited a dose, because he or she or they could be sick, and maybe there's other ways that we have to get the medication to the person then the next few days. So lots of things to think about. We can touch upon this a little bit later when new guidelines come out, but it does touch upon carries a little bit later on. There is considerations right now, of course, for methadone and SROM or slow release oral morphine. Again, when the newer guidelines come out, there will be a little bit more talk about carries and prescribers to base decisions regarding carries on individualized and flexible assessment of the person. And for pharmacy world and also clinicians, a long time ago, I think before 2014, and I've been around for a while, we used to be able to dispense many doses in one big bottle, but that has changed, and it's always individual doses in each bottle to ensure that less errors can be made and proper ingestion of the proper dose. Take-home doses right now, for example, a patient representative can pick up and sign for any home take-home doses in special circumstances. And I'm talking about what if the person was sick. Prescriber needs to just confirm in writing and everything else for a very specific time. And then pharmacy, of course, needs to ensure identification of the person and permission also from the patient. And we document everything to keep everything in place with the original prescription. So I'll go through really briefly. I have a teeny bit of time left of missed doses. So we have to notify missed doses, of course. With methadone, we must notify about 3 days or so. It's not totally absolute, but not a strict limit for the methadose. But generally it is 3 days because there's usually loss of tolerance, etc. Would require reassessments. And if there's questions about that, we can take those questions. In terms of the other ones, 6 or more consecutive doses of buprenorphine naloxone, and slow release or morphine, it's 2 or more because it is a very short half-life. And if anybody is on injectable hydromorphone or some of the other injectable diacetylmorphine, there's certain criteria put into place at the clinic, which I've described here. In pharmacy, we're always allowed to do emergency supply. We've been able to do this. I've graduated over 25 years ago, almost 25 years ago, but we've always been allowed to provide an emergency dispense. And this actually includes a lot of things, including OAT, depending on the assessment of the case at that time. And it's individualized to the patient and individualized to the pharmacist's discretion and also their own assessment process. And we just document everything. And just so that you know, I'm going to send out something else that prescription transfers and carries in emergencies and extreme weathers and all that, that can be looked at a little bit too. And there's something that can be sent out a bit later on to make sure that patients are aware of this. Expansion of pharmacy services, injections. So people have been asking about this. We are actually now, instead of just vaccines, we are in pharmacy, we're allowed to inject intramuscular and subcutaneous injections in sites other than, the deltoid and triceps underneath here, which are the standard vaccine places. But we are responsible to know what we are doing before we can administer certain products. We can also now extend prescriptions. So if a patient does not show up at the clinic, they've been showing up every day, we can use our professional judgment to extend the last prescription length if needed. This is important because we're looking at retention and all that from the OAT perspective, right? And we have to also, as pharmacists, have that necessary knowledge of the drug and an assessment of the case at that time. And like what I said, a renewal is for the duration up to not exceeding the duration that was originally prescribed. So if it was prescribed for a week last week, I could technically extend out that prescription for another week. And this is new since fall to try and ensure that we're looking at retention and everything else to support the patient. So really briefly, I know it was very brief and lots of questions probably thinking through your head, but this is a basic summary. So there's different oral options, there are different injectable options. There's now a monthly subcutaneous option. Lots of drug-drug interactions to some extent. There's a table there for you. Some of the common errors I presented as a patient, I would also look at the prescription and say to yourself, does this make sense before I leave the office? Harmonized forms makes it a little bit easier so that everything is written the same or very similar ways. I went over witness ingestions of the first doses. I went over missed doses. I also went over emergency dispenses and a little bit about the expansion of pharmacy services to try and support patients out there. There's some references will be included at the end here. And are there any questions at all? And I'll just switch over so that I can take a look at the chat as well.